Good morning. Can you hear me?
Good morning, sir. We can hear you.
Okay. Can you see my slides?
Yes, sir.
Okay. Um, so this is an interdepartmental activity. I think the other department taking part is microbiology. I vaguely remember somebody saying that they will post it to the LMS, their lecture. Am I right? Have they done that?
Yes, sir. It is already in the LMS.
Okay. So then I'm the only presenter today, no, at this time.
Yes, sir.
Okay, fine. We'll wait for a few more minutes for the others to join in. Okay, shall we start now because it's now 8:05. So basically, this is on HIV infection, and I'll be focusing on clinical aspects, and also I'll be focusing mainly on showing the pathophysiology of the disease, HIV infection, and the principles of management, rather than going into clinical details. So I will go through three things. First of all, I'll deal a little bit about the natural history of HIV infection. This may have been done already by the microbiology department, but I want to revisit it a little because you have to understand this very clearly in order to know the management of an HIV positive person in different stages, including diagnosis and treatment. And then once I have explained to you the natural history, then I'll talk about the clinical presentations at each stage and the management overall. Just to recapitulate, natural history means what would happen to the patient if the patient was left untreated and allowed to pursue the disease or its outcome according to nature. Now, natural history is very variable among all infections. You know very well that, when you get an infectious disease like, say, dengue or leptospirosis, some people recover, some people get very sick, and some people recover with treatment, and some people die even with treatment. So it's a very variable thing. So what we try to study in natural history is all those various possible outcomes and why someone goes into one category and not the other. Why someone recovers and why someone does not recover, for example. So we have to know all the possibilities in our head. Then only we can, know how to manage the individual patient. So with regard to natural history of HIV infection, you might remember that at the first lecture, I think, or the second lecture I gave you in the module, I spoke about the fact that there are three steps: exposure, infection, disease, and whether you get exposed and infected depends on the reservoir and whether the person is exposed to a mode of transmission. And once a person is exposed, the exposure leads to entry of the pathogen and then establishment in the body, and then there are various possible outcomes. That is, they may get the disease or they may not get the disease, and so on. So I'm just trying to put more information or individual specific information about HIV infection onto this basic framework. Now, the reservoir of infection for HIV are human beings, because HIV is an obligate human parasite. It cannot live in any other animal. It came from chimpanzees. That was called the simian immunodeficiency virus, but now it has evolved into a different virus called HIV. So the HIV itself is a human parasite. It does not live in any other animal. So therefore, the reservoir infection has to be the population of HIV infected humans in the world. And the spread occurs mostly through HIV infected persons who are asymptomatic. That is because those who are symptomatic are very sick normally and in hospital, and they cannot infect others because you need direct contact for infection. So when you know about the mode of transmission, you will understand why that only asymptomatic and fit individuals can transmit the infection. So these are the modes of transmission. There are three. The first is sexual intercourse, and it is more likely through penile anal intercourse than penile vaginal intercourse. The second mode of transmission is transfer of infected blood or body fluids from an infected person to another person. For example, transfusion of or injection of blood or blood products in hospitals. Blood transfusions, for example, can give rise to HIV infection extremely rarely now, because now all the donors are screened through their history and also through various tests like ALT and AST, and also for antibodies for HIV. So therefore, generally the blood and blood product available in the National Transfusion Service in Sri Lanka is extremely safe. I should say one of the safest in the world. So the chances are less than, I think, 1 in a million of getting infected. But there are 2 reported cases of HIV infected persons who got infected purely from blood transfusions. But if someone gets a blood transfusion or blood product transfusion, which is already infected, which is infected by some, which has been missed during the process of screening and testing, then if that person gets the transfusion, the likelihood of becoming HIV infected is more than 90%. Then intravenous drug abusers, they share needles and syringes with each other. And then, as a result, those needles and syringes become contaminated by each other's blood. So that can also give rise to blood-borne virus transmission. Tattooing with needles and instruments which have not been sterilized can also do that. Needle stick injuries in healthcare workers. When we look after our patients, sometimes we suffer accidental exposures to needle stick injuries or scalpel cuts and so on from patients. And if that patient is HIV positive, we might get infected, but the likelihood is very low, less than 1% overall, but it is variable. It depends on how much of blood is on the surface of the instrument and so on. There are various variables which determine whether someone was infected or not. So these 4 ways of transferring infection, that is transfusion, IV drug abuse, tattooing, and needle stick injuries. All these methods, these exposures, transmit all blood-borne viruses. That includes HIV, hepatitis B, and hepatitis C. And it also includes other viruses also, but mainly the 3 that we talk most about are these 3. The third mode of transmission is mother-to-child transmission, which is abbreviated to MTCT. The mother who's HIV positive can infect the child. The likelihood is 15 to 40%, and that infection can take place through the placenta or around the delivery time, that is peripartum, or even during breastfeeding. So there are continuing dangers to the child, to the fetus and the child. And one of the important things is if you can detect mothers who are HIV positive in pregnancy, treating them with antiretroviral medications can prevent MTCT. And Sri Lanka is a country which we recently celebrated zero MTCT in the country by adopting what's called universal antenatal screening. That is, all mothers who come to our antenatal clinics were tested for HIV antibodies, and if they were found to be HIV positive, they were treated with antiretroviral drugs. I'm sorry, the zero MTCT was for syphilis, not for HIV, but we are trying to achieve zero MTCT for HIV also. So we test for HIV and syphilis in all our mothers who come to antenatal clinic. That is called universal screening. That's a very special situation because here is a situation where we test the mother for blood for infection even without her consent. That might sound unethical because normally, as you know, we must take consent to test. But this one situation is an exception because we do it for the benefit of the child, and we keep the information anonymous so that others don't know, unless it is found to be positive, in which case we tell the mother. And of course, in our country, mothers are very keen to make sure that they have a healthy child. So as a result of that, they actually probably appreciate the fact that it was discovered in time to help the child also. So our culture also helps a lot. But in a way, this is a special situation where we test without consent through universal screening. So 3 modes of transmission: sexual intercourse, transfer of infected blood or body fluids, and mother-to-child transmission or MTCT. So once a virus enters the body, it enters into cells that carry the CD4 receptor. That is, that includes helper T cells and cells in the mononuclear phagocytic system, such as various antigen-presenting cells and so on. So now you know that every pathogen needs a receptor to enter the cell. We have all heard about coronavirus needing the ACE2 receptor to enter the cells in the lungs. So similarly, every pathogen needs a receptor to enter a particular cell, some cell in the body. And that is how a pathogen determines its host species. A pathogen can't infect every host or every possible species. It can infect only those species which carry that particular receptor on their cells. So once the virus enters CD4 cells, it spreads with the cells, like helper lymphocytes and the antigen presenting cells. They enter the lymphatics and go to regional lymph nodes, and then they spread in the body. And then they settle in what are called sanctuary sites. Sanctuary sites are places which our immune system cannot reach. That includes the central nervous system, spleen, the testes, because there's something called the blood-testis barrier, and intestinal mucosa-associated lymphoid tissue or MALT. Now, rest of the body, our immune system can hunt in HIV-infected lymphocytes or mononuclear cells and destroy the virus and those hosting cells. But in these sanctuary sites, our immune system can't reach them. So therefore, this HIV can hide inside them, as if like a terrorist hiding inside the jungle, and then continue to exist there, replicating viruses and sending them out into the bloodstream. So the progression of illness is where there is gradual increase in the viral load as those viruses from those sanctuary sites start spilling over to the bloodstream. And since they keep on infecting CD4 carrying cells, gradually the CD4 lymphocytes become destroyed and the CD4 cell count becomes reduced. The CD4 cells are very important in the immune response to various pathogens and various cancers, because it is the CD4 cell which stimulates the effector arm of the adaptive immune response to destroy cells which are infected by intracellular pathogens or to destroy neoplastic cells. So CD4 cells are very important to activate other cells to go and attack those infected cells. What I mean by infected cells is any kind of intracellular infection or intracellular pathogen, like, for example, tuberculosis is a good example. So CD4 cells are very important to stimulate that effector arm of the immune system against any intracellular pathogen or any neoplasm. Now, when the CD4 cells are gradually destroyed and there's a CD4 lymphocytopenia or CD4 cytopenia, then what happens is that our ability to respond to intracellular pathogens in general and to neoplasms becomes reduced gradually. So this diagram is a composite diagram which shows various things all put together. On the left-hand side, the person gets infected, and then about 3 weeks later, develops that green-colored column. That's called the primary infection. And then the person recovers in a few weeks, and then stays okay for many years before becoming sick again. So what happens there is, there's a blue line and a red line. The blue line is the CD4 cell count. At the beginning, it's very high and normal. And the red line is the viral load, the amount of virus in the bloodstream. You can see that as the incubation period ends and the patient enters the green column, that is the primary infection or seroconversion illness or acute HIV syndrome or whatever you call it. In that period, the viral load becomes very high and therefore the CD4 count drops. But the immune system starts kicking in and starts destroying the virus, and therefore the viral load goes down and the CD4 count rises again, but not to the normal level. So at the end of that green area, after the seroconversion illness or HIV, acute HIV syndrome, the viral load remains at comes to a certain level, a lower level, but not zero. That's called the set point. And the CD4 count has also recovered, but not completely. Now what has happened is, at this point, the virus has got itself hidden inside the sanctuary sites, and the immune cells can't attack them. And the virus and those inside those sanctuary sites, the viral replication is continuing, and little by little, more and more virus is coming out in the bloodstream. And when they come out of the bloodstream, the antibodies and cells attack the viruses, but it's a never-ending problem because they can't reach the sanctuary sites. So as they go along, gradually, the viral load keeps increasing, and they keep infecting CD4 cells and destroying CD4 cells. So there's a progressive period called clinical latency, when the viral load gradually rises and the CD4 count gradually falls. And once the CD4 count falls to a lower level, now here it's shown as 1000 or so, the patient starts getting symptoms. First, they get what are called constitutional symptoms, and then they get opportunistic diseases, and then they die. So you can see that until that time, now in this graph, it's about 7 or 8 years. Until that time, the patient is asymptomatic. They are leading normal lives. For example, they will be doing a job, earning money and having children and going around driving in vehicles and so on. And they will also be coming to hospital. They may be coming to hospital to check their blood pressure. They might come to hospital because of an accident to get a suture. Then a woman might come to hospital for a childbirth. And they might come to hospital for various illnesses like respiratory infections and so on, which which happens to everybody. But we don't know that they are having HIV infection. In fact, even they don't know. And they also have sexual intercourse. They might even donate blood in the blood transfusion service. And that is how they spread the infection to others without even knowing that they are infected. Because they are completely asymptomatic. The green colored event, the acute HIV syndrome, is a very brief illness, about 2 to 3 weeks, and it's a self-limiting illness, and they have forgotten that now because they recovered. So it is this period of clinical latency which is important for disease transmission because they are asymptomatic, they are active, and they are leading a normal life and also having sexual intercourse or maybe even donating blood, and therefore transmitting it to others. Once they fall ill, like after year 8, 9 or so, as it shows in this diagram, when that curve goes upwards to opportunistic diseases and all that, at that point they are sick and they can't have a normal life. They can't work, and they might even not be able to have sexual intercourse, and certainly they won't be giving blood donation. So then they can no longer be dangerous to others. Well, not much, because by that time they are too sick to transmit the infection. So the important point is this. Important point is we get transmission to others during the clinical latency mostly. When they are sick, it is much less. And it's the same thing for us also, for healthcare workers who are exposed to HIV positive persons. When they are sick and we test them and we find that they are HIV positive, we take precautions. But when they are not sick, when they are clinically latent, when they come to hospital for various other reasons like appendicitis or childbirth or for a suture or something like that, we don't suspect HIV infection, and it is their blood or needle stick injuries and things which can actually infect a healthcare worker accidentally. Now, this is the reason why we need standard precautions, what used to be called universal precautions, to protect ourselves from those who are in that middle part, clinical latency. One last thing I want to tell from this diagram is that now you have seen the number of years, 1, 2, 3, 4, like that, up to 11, but that is very variable. So, one person might have a clinical latency of 7 to 8 years. They are called slow progressors. Another person might get there, in about 2, 3 years, very quickly. They are called rapid progressors. That's a variable thing. Don't assume that everyone has about 7 or 8 years of clinical latency. Sometimes it's very short. It depends on the virus set point, the viral load set point at the end of that green column, at the end of the acute seroconversion illness. If it is a high set point, they reach the end faster as rapid progressors. Otherwise, they have a longer clinical latency. So the importance of detecting them in the acute HIV syndrome is that you can treat them with antiviral drugs and make their set point lower. Therefore, that improves their prognosis. Now, these are the prognostic factors in HIV infection, why some patients progress faster and the others progress slower. It depends on the virus, whether it's HIV-1 or 2. HIV-1 has a worse prognosis than HIV-2. And also viral strains, they are different to each other. Some strains are more virulent. And there are host factors. And also, as I said, there is the viral load set point. Now, these stages, that diagram that I showed you, is broken down into stages of categories. The World Health Organization has given one classification that's called the staging, the clinical stage 1, 2, 3, and 4. And the CDC in the USA has given another categorization called clinical category A, B, and C. They are roughly similar. The stage 1 is the same as category A, more or less. Stage 2 and 3 is combined into category B, and stage 4 is the same as category C. So if I go to the clinical WHO clinical staging, stage 1 is asymptomatic infection and persistent generalized lymphadenopathy. In the CDC classification, it also includes primary HIV infection, that green column which I showed you earlier. On the WHO clinical stage side, the stage 2 is when the person has unexplained moderate weight loss of less than 10% of body weight, recurrent upper respiratory infection, zoster, angular cheilitis, recurrent oral ulcerations, papulopurutic eruption, seborrheic dermatitis, and fungal nail infection. Now you would see that these are all very common things and very, very trivial things. Angular chelosis can be treated very easily with an antifungal, or recurrent oral ulceration might get better on their own. Seborrheic dermatitis, there are various local applications you can use to treat. And fungal nail infection also, there are various antifungal medications, local and systemic, which can be used to treat them. So these are not troublesome things, but they are the early manifestations of progressive HIV disease. Then when they get to stage 3, this is a bit more serious now. Unexplained severe weight loss, more than 10% of body weight. Unexplained chronic diarrhea, more than 1 month. Unexplained persistent fever, more than 1 month. Persistent oral candidiasis, oral hairy leukoplakia, I'll show you a photograph in a little while. Primary tuberculosis, severe bacterial infections, acute necrotizing ulcerative stomatitis or gingivitis or periodontitis. So that's all dental infections. And unexplained anemia or neutropenia or thrombocytopenia. Now these are a little bit more severe, more serious, but still they are not specific for HIV. They can occur in various conditions. I mean, for example, you know that anybody can get pulmonary tuberculosis. You don't have to be HIV infected. The vast majority of people who get tuberculosis are HIV negative. They get it because of other reasons, like some other reason for reduced immunity. And severe bacterial infections we see every day in the ward. Leptospirosis, we see severe pneumonias, we see. The vast majority of them are not because of HIV, but because, all of us can get a severe infection. Even persistent oral candidiasis is not uncommon, especially if the person is on antibiotics or is using dentures and so on. That's a fairly prevalent condition. So these are not specific for HIV. They can be seen for various reasons. If you look at neutropenia or thrombocytopenia, there are other causes also, conditions like ITP and so on. Stage 2 and stage 3 on your left-hand side, the WHO clinical stage, is combined into CDC clinical category B. There you have some very different set of diseases, bacillary angiomatosis, then cervical dysplasia, then listeriosis, and so on. Now, this shows the reason why the WHO and the CDC categorizations are different. Basically, the CDC USA categorization uses infections or presentations which are common in the USA, but they're not common elsewhere in the world. If you say, take for example, in category B, the first disease is called bacillary angiomatosis. That's a very rare bacterial infection which is found due to a rickets organism called anaplasma, which is found, or which was initially found among the urban poor, the homeless people in New York. So the CDC classification or categorization uses conditions which they see in the USA. Whereas if you look at the WHO, you can see the conditions that they have listed on stage 2 and stage 3 are the things that you are likely to see anywhere in the world, like things like weight loss, chronic diarrhea, persistent fever, candidiasis, tuberculosis, and so on, or dental infections. So these are, of course, very common all over the world, including Sri Lanka. For example, if you ask me what are the common manifestations of HIV infection in Sri Lanka, I think from stage 2, weight loss, recurrent respiratory infections, angular cheilitis, seborrheic dermatitis, fungal infections, they are common. but papular pleuritic eruption is not very common, although it is seen. And in stage 3, I think just about all these things are commonly seen. So the WHO one is better for us because it is more designed for use in broadly in all countries of the world, especially countries like ours, Sri Lanka, which is a tropical and developing country, without much diagnostic facilities to exactly isolate organisms like listeria and anaplasma and so on. Then we come to stage 4 at the bottom. In the WHO clinical stage, we have the AIDS-defining illnesses, diseases. They are specific diseases for AIDS. So when I say specific, I don't mean 100% specific, but actually they are quite specific, but not 100%, because even they can happen without HIV. But when they do occur, we immediately suspect HIV because it is much more commonly seen in HIV-positive persons. Conditions like sometimes cryptococcal meningitis is a good example, which is very uncommon in HIV-negative persons. It's an AIDS-defining illness. Then symptomatic HIV-associated nephropathy, which is a very specific condition for HIV, and symptomatic HIV-associated cardiomyopathy, again very specific, and atypical disseminated leishmaniasis, which is not specific for HIV, but again, it raises the possibility a lot, especially in countries where both conditions are common, like in India. On the other hand, on the right-hand side, the CDC category C is AIDS-defining illnesses, which is like conditions like opportunistic infections and opportunistic neoplasms, which are very common or which are very specific or characteristic of HIV. So I think you don't need to know the examples that I have given there in this table, but it is important to know the progression. So if we look at the WHO clinical stage on the left-hand side, in stage 1, we get the asymptomatic patient who is very active and in latency. But if you examine the person, you will find that there are lymph node enlargements. Then that's called persistent generalized lymphadenopathy, or PGL. Then in stage 2, we have the occurrence of very minor and trivial manifestations like weight loss and angular cheilitis and so on. They are minor trivial conditions, but when they happen, one might think of HIV, although you must keep in mind that the vast majority of people with these conditions are not HIV. Then we go to stage 3, where you have more serious manifestations. Again, they are non-specific. Like, for example, tuberculosis can happen in anybody. And then finally, you get to stage 4, which are far more specific for HIV, although sometimes not entirely specific for HIV. They are called AIDS-defining diseases. So using that natural history story, now let me take you through the clinical presentations you might see in HIV-positive persons. So the first thing that can happen is a primary HIV infection or seroconversion illness. That is, after an incubation period of about 2 to 4 weeks of infection, they get this illness. It's a self-limiting illness that lasts around 2 weeks, and it resembles glandular fever, which is also known as infectious mononucleosis syndrome or IMN syndrome. So they get fever, generalized lymphadenopathy, maculopapular rash, especially if they are given antibiotics of the aminopenicillin group, such as amoxicillin, lymphocytosis, and atypical lymphocytes in the blood picture. When you examine, sometimes there may be mucosal ulcers in the mouth, and also oral hairy leukoplakia, which I'll show you a photograph in a little while. Rarely they can get meningism or meningitis, and also opportunistic infections such as thrush in the mouth. So on the whole, when they come with fever, lymph nodes, and maybe the rash and lymphocytosis and atypical lymphocytes, we think it's a glandular fever syndrome. That's the usual presentation. The laboratory diagnosis of HIV in this stage, the antibody tests are unreliable because antibodies may take anything from 2 to 12 weeks after onset of symptoms to develop. So if you are suspecting HIV in this stage, you must do the PCR or the antigen test, the P24 antigen test. So this is the rash of the seroconversion illness or primary HIV infection. You can see it's a erythematous maculopapular rash. And this is oral hairy leukoplakia. On the lateral border of the tongue, you can see those corrugated, whitish, corrugated, linear appearance. oral hairy leukoplegia. It's fairly specific for, it's a fairly specific finding due to a certain human herpes virus. This is oral thrush inside the mouth. You can see this due to candida. It's a very common thing you can see in various conditions, not just HIV. So many conditions, immunocompromised patients, diabetes, antibiotic use, and so on. Now, then they go on to develop the asymptomatic infection. Antibodies may take a long time sometimes to appear. So you have to depend on the PCR and the antigen test if you want to make a diagnosis. During this stage, there's a progressive rise in viral load and a fall in CD4 count. And they don't have symptoms. They may come to hospital for other reasons like appendicitis or childbirth, or after accident, they might come for a toxoid injection or a suture. If you examine them, you will find that they have those lymph nodes, which I mentioned earlier. So patients are very active, they are transmitting the virus, and they come to hospital for other reasons or incidental reasons, which is the reason why you must all practice standard precautions on all people, on all patients who come to hospital. So learn about standard precautions. They might get minor HIV-associated disorders, which I mentioned earlier. Generally, these are due to immune breakdown in the immune system, and there's a sequence. They first start with getting impaired immune regulation. So immune system is all right, but the regulation is not all right. So they get skin reactions, especially to antibiotics, immune thrombocytopenic purpura or ITP, Guillain-Barré syndrome, or transverse myelitis. So these are diseases of immune dysregulation. In the second stage is they start getting mild immunodeficiency, so that manifests as usual infections in unusual presentations, such as more severe or more complicated or more unresolving or recurrent or frequent infections, but the infection itself is a very common infection or usual infection. Or sometimes you can get unusual mild infections like infection of skin, nails, hair, and so on, which are mild but unusual. Or you can get vague persistent illnesses like fever, diarrhea, weight loss, and lymphadenopathy. Then the third stage is they get more marked immune deficiency, giving rise to opportunistic infections due to pathogens which don't normally cause infections in immunocompetent people, unlike in the infections of stage 2, and also opportunistic neoplasms. And finally, the stage is acquired immune deficiency syndrome or AIDS, which is diagnosed when the person presents with what is known as a AIDS-defining disease or illness. So this rash is actually due to amoxicillin in an HIV-positive person. So that's an unusual manifestation, but it can happen in other people also. This is the condition called papular pruritic eruption, a very itchy papular rash due to a fungus called penicillium, which is sometimes seen in Sri Lanka also. And this is zoster or shingles. In one particular dermatomitis must be T9 on one side. And although shingles is a common thing, if it occurs in a young person, especially, we must test for HIV. And this is seborrheic dermatitis, which is quite common really in many people. And we see it every day basically in our skin clinics. They are not all HIV positive, but if they come with troublesome seborrheic dermatitis, they should be tested for HIV also. And chronic nail infections like chronic onychomycosis, like in this photograph, again seen in lots of HIV negative people, but if it is troublesome, you might consider doing a HIV test. Right, so I come to the last stage, the management of the HIV positive person. There are 5 steps that we have to go through in the management of the patient. The first thing is to manage their symptoms. That's the most important thing because they come to you because of symptoms. So the first thing is to solve their symptoms, managing their symptoms. And once that is done, you go to the second stage of improving their prognosis, long-term prognosis. HIV is a long-term condition, and by giving antiretroviral medications, you can improve the long-term prognosis. So now they are symptomless, and they have a good prognosis on the long term, hopefully. Then they will have various concerns, various worries about the future. So that's the third stage, managing concerns. Along with that, you must also start preventing further complications and finally preventing further transmission to others in the community. So number one is managing symptoms. Common symptoms in Sri Lanka are weight loss, and sometimes they are worried about the appearance, especially when they get antiretroviral therapy. It changes the appearance because their fat levels dissolve away, or that's called lipodystrophy, and because of that, they get a very different appearance on their face. The cheeks are sunken in, and so on, and they are worried about their appearance. Sometimes they come and ask, doctor, can't you do something about my face? And other symptoms include diarrhea and fever. Improving prognosis, antiretroviral medications improve the prognosis immensely. It is recommended for all HIV-infected persons, irrespective of the stage or category. And there are 5 types of drugs which are used in the country in the world at the moment. They are called NRTIs, which stands for nucleoside reverse transcriptase inhibitors. Then NNRTIs, that is mononucleoside reverse transcriptase inhibitors. Then PIs, which are protease inhibitors, integrase inhibitors, and chemokine receptor inhibitors. Of these, I think in Sri Lanka, we have the first 3 in NRTIs, NNRTIs, and PIs. But when they are started on antiretroviral therapy, something very interesting happens. Their immune system starts to recover a little bit. And when they start to recover, they start reacting to antigens which were lying around in the body, for which they were all this time not responding. And that causes various inflammatory syndromes. That's called the immune reconstitution inflammatory syndrome, or IRIS. So the first thing to improve prognosis is antiretroviral treatment. The second thing is to detect and control comorbidities, because now these patients on antiretroviral therapy, unlike in the past, they are able to live for many, many years. They live for 10, 15, 20 years sometimes. So they are going to get other problems like everybody else. They are going to get dyslipidemia, hypertension, metabolic syndrome. And dyslipidemia and metabolic syndrome are very common after starting antiretroviral therapy. So you must check their lipid profile and so on and correct it. And they also get lipodystrophy. I mentioned earlier also about the appearance. The lipodystrophy can give rise to a bad appearance, and they might be worried about that appearance. And you must arrange for follow-up so that they continue to take their medications and do the testing and so on. Follow-up is very important. They can't stop medicines. They have to continue it for life, and they must be monitored and followed up and looked after continuously. So that is improving prognosis. In managing concerns, now, of course, they have all kinds of concerns. I just listed some here. We have to answer all their questions, so we have to give them information. They might have a very different world view after getting HIV, so you need to give a lot of psychological support, social support, and also think about their spiritual health. They are very concerned about confidentiality. They don't want others to know that they have HIV, so it's very important to maintain confidentiality in everything that you do. Make sure that their records are kept very secure and so on. And sometimes they worry about their deterioration in the future and death, so they might give advance directives about what should happen to them when they become very sick. So that's about managing concerns. And the fourth is preventing further complications that we do using chemoprophylaxis, such as we give cotrimoxazole to prevent pneumocystis infection and cerebral toxoplasmosis. Sometimes we give macrolides to prevent mycobacterial avian complex infections. And there are some other antibiotics which are given in some countries in the world, but not everywhere. For example, in India, they give isoniazid to prevent tuberculosis. And sometimes they are given fluconazole to prevent cryptococcal infections. So the first 2 are fairly straightforward and standard, cotrimoxazole and macrolide, such as erythromycin. But isoniazid and fluconazole are more controversial. And then they also need to be given vaccines, but you must only give inactive vaccines. Don't give active or live vaccines. And they must be given as early as possible, because the earlier you give them, the better their response. So we vaccinate against hepatitis A virus, hepatitis B virus, influenza, tetanus, whooping cough, and diphtheria. The triple vaccine. Then they must have cancer surveillance, because they have a slightly increased chance of getting cancer. And you must give them advice about lifestyle. For example, safe food, safe water, so that you won't get infected with various salmonellas and so on. About sports activities, about having pets, which can give you infections, and also about travel, which can give you traveler's diarrhea and other conditions which are also infections. So they must be given lots of lifestyle advice so that they don't get complications. And finally, preventing transmission. They must be taught about having safe sex or rather safer sex to prevent transmission to others, and also not to get infected with other viruses oneself, because there are various HIV strains, and even they can get a new HIV strain infection from another person, especially a mutant or retroviral drug resistant strain. So they must prevent transmission for the sake of others as well as oneself. And there are other viruses also which they can become infected with, like herpes simplex virus, human herpes virus 8, and hepatotropic viruses such as hepatitis B and hepatitis C. So for those reasons, for their own good and for the good of others, they must practice safer sex. Okay, so basically that's what I wanted to share with you. Do you have any questions about clinical aspects of HIV? Right. If a pregnant mother is found HIV positive, can we stop the fetus from getting it? Yes, you can. That is why we do the universal screening. If they are found in the first or second trimester, we give them antiretroviral. We give the mother antiretroviral medication and reduce the viral load, and that reduces the infection from the placenta and during delivery. And after the childbirth, we give the child also, the neonate also, antiretroviral medication, and we generally discourage breastfeeding. We have to give the child antiretroviral medications for I don't know exactly how long, but for about a few months, I think. What is the new cure said to be found for HIV/AIDS? There is no cure, but medications are becoming more and more effective, and perhaps very soon there may be a cure, but still there is no opportunity to stop treatment. You have to continue treatment. Are there cases of full recovery in primary viremia without progression to latency? After getting primary HIV infection, I don't think there are cases of recovery, but there are reported cases of people who got infected but didn't progress to viremia or primary infection or latency. That is supposed to be because they lack a certain receptor called CCR5, which is necessary for the virus entry into cells. So virus entry into cells requires two receptors. One is CD4, other one is CCR5. So CCR5 is called a co-receptor. So people who have a congenital defect or congenital deficiency of CCR5 apparently don't have an immune problem, but they are because their immune system is still normal, although lacking the receptor. But they are lucky because they won't get the HIV infection establishing inside the CD4 cells. So there are examples of people who got infected, who basically have antibodies. That's how we know that they got infected, but who never developed any HIV establishment in their body. But as far as, if I'm not mistaken, there are no cases where after seroconversion illness or after primary virus infection, there are no cases of spontaneous recovery or spontaneous cure. After how long we can do the rapid diagnostic test for HIV? Well, yeah, basically, the rapid diagnostic test uses the antigens, and if it is positive, you have to do the confirmatory test with another antigen test. That's called the Western blot test. And the rapid diagnostic tests are usually considered unreliable anyway. But unfortunately, that is what is available everywhere, because the better screening test is called the ELISA test. We can use it in seroconversion illness, but if it is negative, we should not stop there. We must do the PCR or P24 also. That is during seroconversion illness. But if you see a patient after seroconversion illness or without seroconversion illness, whether you depend on the antibody or antigen or PCR depends on on what you think is the stage. Like for example, if you think it could be the latent period, you may have to do the PCR or antigen also. But if it is already progressing with general lymphadenopathy or whatever, then of course antibody tests are enough. So it depends on the individual patient on that graph. If I can go back to the graph, then I think I can, it will be easier for you to understand. Let me go back to that graph. Now in this graph, in the green area, you can't depend on the antibody test. You can start with the antibody test, but if it is negative, you must do the PCR or antigen test. That's in the green area. Now after the green area, in that clinical latency period, the more towards the right-hand side, the more you can depend on the antibody test. And the more towards the left-hand side, the more you must go do the PCR and antigen test also. But how do you know whether a patient is in the right-hand corner or the left-hand corner in a given situation? That is very difficult to say. Sometimes in latency, now I'll give an example, then you'll understand better. A patient comes to you and says, doctor, I had sexual intercourse with a commercial sex worker in Thailand. Can I do the HIV test? Now, then you can ask the questions, you can ask more broadly and find out whether there were, how many exposures were there and so on. So you might find that the person may have had, say, let's say 3 exposures. The doctor, he says, one exposure was 5 months ago, one exposure was 2 months ago, one exposure was 1 month ago. So, in order to cover the 1 month ago exposure, you must do the PCR or antigen. Whereas if the person says my exposure was 6 months ago, then of course only the antibody test is adequate. So it depends on the case, whether you feel that the patient is more towards the green column or more towards the red side. If there was mother-to-child transmission, when should the baby be tested and treatment started? And can the child be expected to be cured as the infection was caught extremely early, or will the child have to be on ART throughout life? The second is easier to answer. They can't be cured. They must be on treatment for life, and that's very unfortunate, but that is the truth. When should the baby be tested? Well, if you do the PCR test, you can do it even in the early stages. And as you know, you can't do antibody testing in neonatal cases because you might detect the mother's transmitted antibodies. So basically, you have to depend on the HIV PCR or the antigen in the child. But later on, like if the child is 6 months old or 1 year old or something like that, then you know that the maternal antibodies have disappeared from the child's circulation. Then you can use the antibody test also. Why is anal intercourse more likely to transmit HIV? Because it causes more trauma. Vaginal intercourse causes less trauma to the vaginal mucosa, and therefore there is less, not only vaginal but even the penile mucosa. So therefore there is less chance of blood admixture between the two partners. Whereas in the case of anal intercourse, there is greater chance of mucosal injury to the penis as well as the anus. So therefore there is a greater likelihood of blood admixture. But of course, even vaginal secretions and semen do have the HIV virus in them. So therefore, even without any kind of trauma to the mucosa, with simple, with non-traumatic sexual intercourse also, one can get HIV transmission. What I'm saying is that anal intercourse is more likely to transmit the infection rather than vaginal intercourse. Any other questions? Some of these questions you asked me were actually should have been answered by the microbiology department. So please check their presentation also. You may find that their answers are more clear or more descriptive than the answer that which I gave you, especially with regard to diagnosis about antibody test and so on. Are there any other questions?